one more. All right, well, welcome everyone. Welcome to everyone who is here in person. Welcome everybody who is watching online. I'm Steve Asarian. I'm the Business and Career Librarian here at the library, and it's my pleasure to introduce this iteration of Seniors Be Well at GRPL, Ask a Lawyer, Ask a Doctor about Advanced Care Planning. So for our first session, I'd like to introduce Claire Bellavender. So I got that right. She hails from Sault Ste. Marie, and actually got her undergraduate education at GVSU and was educated in medicine at the University of Medicine and Health Sciences at St. Kitts. And she enjoys not only cooking, nonfiction reading, and Antiques Roadshow, but she also enjoys, in terms of her professional interests, sleep medicine, women's health, and LGBTQ plus health issues. So thank you very much, and Claire, why don't you come on up?
Hey everyone, my name's Claire. Thanks for all being here, and I hope by giving this presentation, I can start a discussion for all of you and your families to start on with advanced care planning. I see patients every day in the hospital and in the clinic, and this is something I bring up, and about a third of Americans have advanced care planning documents, and the rest don't. So hopefully after this presentation today, a few more will have some. So what is advanced care planning? It's a process where you and loved ones will set goals with respect to your medical care. This can involve key healthcare providers, so whether that's your primary care physician, maybe a home health nurse, medical people that that know you or that you get care from, family and friends as well can be a part of this decision. Anyone that you love and may be able to help you kind of draft what you would want end of life or during the aging process. When do you start advanced care planning? The answer to that is now, yesterday. It can be done at any point in one's life. It doesn't need to happen at age 50 or when you get your AARP card or when you get diagnosed with a new disease or illness. It can happen at any time, regardless of your current state of health, and I recommend starting advanced care planning as soon as possible for both young and old people. So what is a healthcare advance directive? So this is a general term. It's used for any document which includes instructions about your health, treatments or measures you would or would never want, and a possible appointment of a medical decision maker. This can include a living will and a durable power of attorney, but I won't say too much more on that. Two things that are often included are something that we call code status at the hospital. If you were to come into the hospital today and I were to admit you to our family medicine service for a few nights stay, I would ask you these two questions. In the event of an emergency, would you be okay with us performing chest compressions, so CPR, and possible medications and electric shock to try to restart your heart? Usually, at that point, people look at me and say, oh my God, why are you asking me this question? Do you think I'm going to die? And I say, no. I ask every person that I admit to the hospital if they would like CPR. And so at that point, you either say yes or no, and then I follow that up with, in that same emergency, say you're unable to breathe. And often when your heart isn't working, your organs and your brain aren't getting the oxygen perfusion that they require. So in that time, we usually intubate a patient, which is putting a tube down someone's airway and then breathing for them. And this is just a temporary measure. This is not, I'm not putting on long-term life support. This is a temporary solution to try to resuscitate you. It doesn't mean that you might need intubation to be intubated long-term. But in that emergency situation, there's no way to know for sure what's going to happen. So the chest compressions and the intubation are two things that we do because your heart has stopped working and you're no longer breathing. So it's a drastic measure to kind of save your life. Unfortunately, it doesn't always work. And a lot of the times, as lay people who don't work in a hospital, we see these things on TV, and usually they're pretty successful. I think I read a statistic that about like 60% of CPR attempts on television and movies are successful, whereas in real life that's not the case. As we get older, CPR becomes less successful, but it's still something that you may choose to do, given a last-ditch effort to kind of restart your heart. But there are complications that can arise from CPR and intubation, you know, just like with any medical treatment. A lot of times, too, with CPR, we see people will have broken ribs. The chest compressions we do are pretty forceful. So that's a whole topic that I could go into about the nuances of CPR and intubation and the downsides, the pros and cons for both. But the main thing is that what I want you guys to know is that when you come to the hospital, when you're discussing advanced care planning, these two things will likely be a part of that discussion in regards to a do not resuscitate order. So I wanted you to be familiar with what CPR and intubation are. Does advanced directive mean do not treat? So advanced directives, they express both what you would want in terms of medical treatment and what you wouldn't want. So for example, say you don't want to die in a hospital, which is a really common thing I hear very often. If that's the case, talking to people you love, your physician, about options to potentially die at home. So hospice care, palliative care. This is just one example of what you could have in an advanced directive. You know, people may also include organ donations, tube feeding. My mom always says, don't ever give me the thickened liquid. When patients are unable to swallow, we add a thickening agent to make thin liquids thick so they are easy to swallow. My mom says, if you ever give me thickened water, I'll come back from the grave and haunt you. So trying to decide what's something that I would want if I was sitting in the hospital and I was unable to really communicate what my needs and desires are. Also, maybe you'll say, I don't want my son involved or my daughter-in-law or my ex-husband. It's important to include who you would not want involved in your care, as well as maybe, so when you think about treatments and treatment options and interventions, but also think about who you would want present. At bedside, where do you want to be? Do you want to have music playing? I mean, there's so much that you can add to make this not only informative but personal. So I recommend that being a part of the conversation that you have with loved ones. So once you fill out your advanced directive, your task is not done. So the first thing that I want you guys to do is know that, say you talk to your family, you've drafted up an advanced directive and a plan. I want you to make an appointment with your physician so they know kind of what your wishes are, and make sure your wishes are reasonable too. You're not healthcare professionals, so you may have some things laid out, and it's good to go over those things with a physician and just make sure that all of that is kosher. And please keep a copy of these documents with you. Keep one in like your records at home where you store important papers, and then it's also great to keep one at your primary care doctor's office but transfer to a different facility. Say you normally come see me at St. Mary's Hospital, but you get admitted to Spectrum or Metro. They won't necessarily have your advanced care planning documents and what your medical wishes are. So make sure you bring a copy with you if you're at a different facility, or a loved one has a copy that they're able to bring in, and then we can put in your medical record. And then, so say you hear this presentation today, and you fill out all your advanced care plans. Think about what kind of medical treatment you would want. But these things aren't set in stone. And when I see people in the hospital, and they're unsure about a decision about CPR, and they make a decision, and then I see them the next day, and they say, I've thought about this a little bit more, and I changed my mind. You're able to change your mind as many times as you want. This is your paperwork. This is your life. This is your end-of-life planning. So I tell people it's good to revisit your advanced care planning documents when you reach a new decade in life, when maybe you experience a death of a loved one or a spouse, if you go through a divorce, if you're given a new diagnosis, or if you suffer a decline. These are all good reasons to look and revisit the documentation you already have in place. And another thing I would like to say that it's really hard to predict every clinical situation possible. When you're going through your advanced care planning documents, you may think, well, let's say I was in a traumatic accident, a car crash. Let's say I got COVID and needed to be on a ventilator. There are certain situations that may come to mind and you'll have thoughts or feelings about, but there are other things that you may not think of because you're not medical professionals. How would you be able to think about every clinical scenario? So the best advice I give for that is that you are an expert on you. And this can be very overwhelming to try to spell out what you would want in every situation. What I recommend is think about what gives you meaning in your life and what's important to you regarding your quality of life. That way, instead of trying to think about all the bad things that could happen in every scenario, think about what's important to you. So whether that's, it would be hard for me to never see my grandkids again. It would be hard for me to live a life where I was secluded from my family. It would be hard for me to live a life where I couldn't eat the foods and that, I love. So including that are important to you and that give your life meaning will be a benefit to include in your advanced care planning document. And this isn't just about you. It's about people you love. And when you're unable to speak for yourself, this will make things easier for your family and friends. So back to this thing, think about what makes your life worth living. And this can change. It can change depending on where you are in your life, your family that you live with. Say you were living with a spouse and your spouse passes away, and now you live by yourself. How does that change your answer to this question, if at all? A really great resource for this is called the Conversation Project. I actually can pull it up. I have some paperwork that I have made for everyone in attendance, and the point of this is that it's really hard to talk about end of life and getting older, and this is a great prompt that almost is like journaling, for lack of a better word. Let me tell you. Let me pull this up right here. So this is like PDF that has prompts that you can fill out and will make it easier to fill out in a directive. And I really recommend, Easter's coming up, so picking a holiday and maybe getting together with family and friends and just starting a conversation about advanced care planning. Never a good time to do it. It's a hard conversation to have, but I think normalizing aging and normalizing decline in physical and mental health is something that we all will personally experience, not only with ourselves, but with people we love. And so I'm starting to talk about it now. When I decided I was going to do this topic, it was around the holidays, and so I brought this up around Thanksgiving, not only to my family, but to my in-laws, which went over well eventually. You know, I explained that. I said, hey, you guys, and this is a weird thing to kind of bring up, but this is really important. And both of my parents and my aunts are very healthy and young. They're 50s, 60s, but things happen all the time. Emergencies happen, accidents happen, and I thought it was important for not only myself to have one of these, but to start having this conversation with the elders in my life who I will eventually be responsible for as they age. So let me just pull up. So the conversationproject.org, this is their website. It's wonderful in regards to resources. They have multiple guides, how to have a conversation, choosing a healthcare proxy, dealing with people who have dementia and Alzheimer's. That's a whole other topic regarding to advanced care planning. Also, like being a caregiver for someone who gets has memory issues or starts to a decline in their health. So this is just a great resource, some time to look at. And then let me pull the PDF. So this PDF that is available for you here is great because this kind of allows you to step-by-step fill out some questions. Like, what does a good day look like to you? Who's your support person? Just to get you thinking about what's important to me, what's important for my mental and physical health on a day-to-day basis, what do I want? And if you're able to answer these questions and have this, it will be easier for your family and friends to also make decisions in the event that you are unable to. There's also another site I found out about recently called ourcarewishes.org, and you can go through some of their documents here, and they'll make a custom document that has all kinds of information that you created compiled together, so you'll be able to hand that to your physician and people you love, including like organ donation, quality of life stuff, medical treatments. So, you know, the big thing I want everyone to take away from this conference or this presentation is that start thinking about what you want for your mental and physical health as you age, and make an appointment with your primary care physician and have a conversation with them. Talk to family and friends about what you want and maybe what they want and what they think, what their experiences have been with other loved ones, and just start normalizing the process about talking about aging as well as death, which is an important part of life. At this time, that's all. Do you guys have questions for me? I could really talk about this more, but what questions do you have?
Yes, Doctor.
Yeah.
So right now, Dr. Bellavender will take questions to the floor. We do have some questions prepared from patrons who might be watching online and things of that nature. But I'll be coming around. Just raise your hand, and I'll come around with a microphone, and we'll make sure that everyone can hear you, whatever questions you might have.
You said to keep a copy of this. So always got it. But I keep trying to think. Okay, how would a copy get there? My position is a hospitalist. So how does having it at the doctor's office get it to the hospital? Does my son just need to keep one in his glove compartment if he ever has to run to the hospital? How do you make sure they've got it?
So question. So. Now we have like an electronic health record, and so if you see your physician at the office, they should be able to taking a copy into your electronic record, and more often than not, we're able to access the documents, even if we're treated at a spectrum doctor, and you come see me. More often than not, we're able to access things. But technology is a blessing. It's also a curse, and sometimes it is difficult. But yes, I would recommend if you came into the hospital and I asked, and you came in, you weren't feeling well, but you need drastic life-saving measures. If you did, we would probably give them to you, not knowing how to do not resuscitate order or what your wishes are. Because in an emergency situation, we'll do everything we can to try to keep you alive. But you come in, I would ask you, I would say, hey, do you have advanced care planning documents? And you would say, you know what, I do. But I don't have them with me. And I would say, that's okay. Have your son bring them in your stay, and then we can scan them and make sure that they're in our system as well. So while you don't need to keep them in yours or your glove box, it's a good time to, if you're at the hospital, or time you go to your primary care doctor, to say, hey, do you have a copy of this? And some places transitioned from paper charting to electronic charting, and some things get missed. You know, wasn't a perfect transition. I don't know, maybe where you're at, they still do paper charting. So that's something to kind of, if they do paper charting, we might not have it in the electronic medical system. But great question, and we deal with this all the time. Most of my patients that come into the hospital, they're like, oh, I do have advanced care. Yeah, but I don't know where it is. And then, you know, we bring it up again and say, hey, we didn't have advanced care plan documents. And then, you know, a son or a spouse comes in or a daughter, and then usually figure it out. But good question. Yeah.
Why do you think only a third can have this in place? What's the thing that holds them back?
Lots of people don't want to talk about death and decline. It's scary. Sometimes I have some patients will say, I don't want to speak in existence. So that's a good question. So I think the fear component, and kind of kick the can down the road, like, oh, that's something to talk about, but you know, I'm pretty healthy right now, or you know, I'll think about that later, or maybe at my next doctor's appointment, and it just kind of gets pushed to the side. Physicians should bring it up too. I usually, when patients turn 50, 60, I try to incorporate it into my physical exam. But it's a discussion. It's like a quick, hey, you know, do you know about this? Great, come back and see me. You know, patients often have questions. So it's a time-consuming talk. So sometimes physicians drop the ball because they don't have the opportunity of time to discuss advanced care planning documents with all their patients. So therefore, people don't have them. And then patients will say, well, the doctor hasn't brought it to me. I'm healthy. Why do I need this? So then kind of the blame gets pushed to someone else. So then people don't take responsibility. And then again, like, there's a fear component as well. And so I think bring it up at a holiday or planning a dinner party or a get-together where you talk about it not only will benefit you, but will benefit the people that are discussing it with, because maybe your daughter-in-law could use one for her mom. So it's a great opportunity, now having the and all of you to increase that 1/3 of Americans, try to get it up, maybe 2/3. At least there are some cities where those numbers are better. It's health systems where they've made it their prerogative to increase advanced care planning documentation, and I think that we can get there. Good question.
Okay, so this question comes from the internet. What would you say is the biggest misconception of the end of life you've seen from a medical perspective?
Dying is really hard. It's not a fun, easy, smooth thing. And sometimes I think we have this misconception that we'll just maybe peacefully die in our sleep, which is nice and does happen for some people, but death can be a very long process. It can be very painful, if not for the person who's actively dying, but for family members as well. And I think like advanced care planning make the process of dying and aging more graceful and just a little bit easier. I don't know who asked that. So, I mean, but again, this is part of life, and it can be a really wonderful part of life. It's not easy, but having your wishes laid out and emphasizing quality of life measures will make the process of dying and aging significantly easier and hopefully more enjoyable, which is, again, not always easy to say. You know, death is not necessarily an enjoyable process. When my grandpa was in the process of dying, my grandma was such a heavy burden for her to carry, and she said it's so hard to see him in so much pain. This is so difficult. And I tried to reassure her that this is normal. Everyone goes through this, and that he isn't cursed and have terrible long death. This is just how it is. And I think normalizing that a little bit made it somewhat easier for her. But again, being surrounded by friends and family and knowing what his wishes were made it a lot easier for all of us. So.
So another question, so we've talked a lot about the advanced care planning,
Yeah.
like having that plan in place, and it is a part of, part of the kind of things that you're supposed to do. How do doctors ensure the patient has the freedom to choose care within this process? What are you thinking when someone is entering your care, balancing, making sure that they're as comfortable as possible and they're as free as possible and that they're as safe as they possibly can in this process?
That's a great question, and that usually involves a team of medical support. And it wouldn't be just me seeing you in the hospital. It's your nurses who are assessing you as a patient and kind of what your needs are. It's discussing with your family at bedside and saying, ooh, well, maybe you said you didn't want this, or your mom doesn't do well with these types of medications. Here are some other options. Would you consider these things? So having constantly an ongoing conversation, so it's not just me making the decisions as your physician, what I think is best for you as my patient. It's a medical team. And say I feel uncomfortable or I'm not sure. At our hospital, we have palliative care. We consult them. They involved. They are happy to visit goals of care, which is a discussion that they often have. And sometimes that discussion involves you as a patient. Times you're unable to participate in that discussion, and it involves family. I will often participate in those conversations as well. Same as hospice meetings and family meetings. I participate in those meetings as well because I want to make sure that my patient is getting not only the best care, but getting what they want and is best for them from a medical standpoint, but also best for them from a autonomy standpoint. This is your life, and I tell people when you're at the hospital, you're not a prisoner here. You can refuse any treatment. You can walk out the door if you want. These are just medical suggestions that I'm making, and it's totally up to you to agree or disagree with my medical opinion. So hopefully that answers the question.
Is there any more questions from the floor? All right. Well,
cool.
Thank you, doctor.
Yeah, of course.
Appreciate you. And when we, depending on how things are working towards the end, we might have you come back up.
Cool. Okay. Let me just maybe.
let's have a round of applause for the doctor. Thank you very much. So I'd like to welcome to the stage Gregory Hodge, JD. Gregory Hodge is an attorney who specializes in assisting Michigan residents with protecting their estates and their family. He's originally from Flint. He's a graduate of Thomas Cooley Law School, and he got a bachelor's from the University of Michigan, Go Blue. And we're very happy and pleased to be able to welcome him today. So thank you.
Hey everybody, and I'm going to try to piggyback off of where you were talking and just continue the conversation about advanced care planning, but I'm not going to dwell so long on the documents you talked about, but I am going to emphasize having a power of attorney by far is the most important document you can have in your advanced care plan for medical decisions and financial decisions. These are two documents that I make sure I tell every client, if you're going to do nothing else, get those. They help you here while you're alive, and they authorize you to step in and make decisions as you wish and per your instructions when you are unable to do so yourself. Now, to go further into advanced care planning, a topic we're going to briefly talk about here is estate planning. So those documents, the medical and financial power of attorney, are very significant and important. If you don't have them, one thing I will say, everybody has a plan. The state of Michigan has prepared one for you. Whether or not you want to go state of Michigan's directives and go through the probate court to have that plan actually come to fruition, that is why we tell people to do it themselves. So, you know, everybody should also look at what they have in their estates and make sure that they make planning steps for what happens after they pass. This is what we refer to as estate planning, usually through a tool called a trust or a will. As an estate planning attorney, we always try to look at avoiding probate, keeping everything private within the family, and making sure that everything in your estate goes as you wish and as you direct. So that part of estate planning is not where I'm going to spend the majority of my conversation, though. Estate planning attorneys often focus on what happens when you die. I specialize in am an elder law attorney, so my focus is not on what happens if you die, it's what happens if you live. And I'm seeing this more and more. I've been doing this for over a decade and helping families, and I'm seeing people live well into their late 80s, 90s, even into their hundreds. And we all know this. The older we get, the more frail we become. I was blessed to speak with somebody in their mid-90s yesterday, in perfect health, still driving, still had their full capacity. Amen, that's awesome. I also have a client who's in their mid-60s with advanced dementia and cannot connect with reality anymore. So age is not always the decisive factor. But I know, I'm not that old, but I know the older I get, the longer it takes my body to heal, right? And so as we age, a medical event diagnosis can create a need for care beyond what your other care has been through your whole life. We refer to this as long-term care. Generally comes in the form of home care or somebody needing assisted living care, so you go into a community to have on-care services, or at the top end of the spectrum, it's skilled nursing care. The example I always pull out to clients is say, you know, if you were to fall and break your hip, what would happen? They'd rush you to the hospital, they would fix the broken hip, and then you would end up going to a place of rehab. The rehab facility is the skilled nursing facility. Now, people say, Greg, I have Medicare. Shouldn't that take care of the cost of my care? And the answer is no. Medicare is what we call a get-well program. So it will pay for your rehabilitation, and the general rule was always to say up to 100 days. Realistically speaking, I'm going to happen for about 2 to 3 weeks before the rehab facilities are saying the individual has plateaued or the rehab is gotten them as they're going to get. When that happens, a big question hits the family. Can I go home? Is it safe to return home, or am I going to need some help? Do I need to stay at this level of care in the skilled nursing facility? Can I go home with some home care? Is there family around that can help me? The conversation, I love the conversation starter that you were bringing up, because this is the conversation that often happens when a diagnosis or a medical event happens. And a lot of families tell me, you know, oh, it's too late. You know, we've already diagnosed this. They're in the hospital right now. And I actually just said it before I started the seminar. I said the only time it's too late is when you die or if you run out of money. And to bring up the concept of money, it really seems off topic of care, but you got to pay for care. The cost of care is rapidly rising, and if you're not familiar with numbers, I'm going to share some general information here, and just so you know that home care, if you were to pay an agency to come in, roughly is around $25 an hour. Do some quick math for you, 6 hours a day, 3 in the morning, 3 at night, out a month is going to run roughly $4,000, and that's for a quarter of your time. Assisted living is also another care option, and the price of that can range anywhere from $3,000 a month upwards to $7,000 or $8,000 a month. And then the skilled nursing level of care is roughly $9,000 to $12,000 a month. Okay, so I told you Medicare would pay for the rehab, but then they stop. And you've got to pay for care beyond that point unless you can access benefits through Medicaid or VA. I apologize. I could spend probably an hour on each thing I'm bringing up right now. I did provide a folder with a seminar that I do that has information in it. I'm going to try to share that information as well so the library can share that with the people that are viewing online. But I'm going to hit these topics quickly and let you know they are there to help families pay for care when the cost of care becomes so excessive that it's going to ruin everything a person has. And you've spent your entire life saving up nest egg, building up for your retirement, and the cost of care can rip through what you have in a matter of a year or two, even if you have $200,000 or $300,000 in your savings. This is the fear that I see in all my clients' faces when they come and talk with me and say, well, I don't want this situation to happen to me or my wife. I don't want to have my care expenses leave my spouse impoverished. And these programs, Medicaid, VA benefits, they have asset limits and they have income limits, and there are rules for eligibility. To quickly tap the rules of Medicaid, a person not qualify for Medicaid unless they have $2,000, less than $2,000, a house, a car, and a prepaid funeral, right? So you've spent your whole life building up a nest egg, and now the benefits that are there to help you pay for care are out of reach until you've basically spent through everything you have. If you are married, your community spouse is enabled and entitled by law to keep half of the estate, a minimum of around $26,000, a maximum right now of $137,000, rounded numbers. Take it one step further. Any married couple sit in front of me. I've had people sit before me with over $500,000 and was able to do special planning to shelter what they had for the community spouse or the healthy spouse and qualify the needy spouse for Medicaid. So numbers, when it comes to these benefits, have to be followed. I advise all my clients and look at what they have and tell them this is what would happen if you did nothing. And basically I could show you how fast it would through every in your state, and then you would qualify. But within a few steps of planning, getting your estate planning documents, as the doctor was talking before me, and starting with those advanced care directives, as well as a financial attorney, will be the first tools we turn to make sure we can do planning to help you when the time comes. There's a program through Medicaid that is called the My Choice Waiver program. This is another program that actually, if you qualify for Medicaid, you can have care services come to your home for the Medicare program. Same requirements as Medicaid, except they have an income cap. So if your monthly income, the individual's, is over $2,523, you won't qualify for this home care program. Again, I can dive deep into this, but if you want more information on My Choice Waiver, the Area Agency on Aging here in Kent County is a tremendous resource of information I shared, as well as you can always call my office or any elder law attorney to be able to give you more information. The benefit I want to touch on here, and doing good at time, that's good, is the VA benefit. So I'm an accredited agent with the Department of Veterans Affairs. I actually got into being an elder law attorney by helping my own family. Grandpa was a World War II merchant marine. He passed away in the 1980s and was told there was no help for him through the VA. Unfortunately, that was incorrect information. I can't tell you the number of veterans that I come to talk with that are told there's nothing to help you, only to out there is. So there are a lot of programs of the VA. The one I'm going to talk about today is a non-service connected pension. It's referred to as aid and attendance most often. It is wartime veterans and their surviving spouses. It can provide up to, for a married veteran, up to $2,300 a month to help pay for home care or assisted living care for the veteran. I believe it's around $1,300 for a surviving spouse. So in order to qualify for the benefit, your veteran has to have 9 days active duty, one of those days during a period of war. So if you fall within that criteria, you are service eligible. The component is there has to be a medical need. So if you need help with 2 of the activities of daily living, your doctor will certify that yes, you need help with medication management, or you need help with anything, or hygiene, going to the bathroom, getting dressed, transportation. You need help with these things. That means the medical component is now met. The final part of the VA benefit to briefly discuss that the VA has an asset cap of around $130,000, meaning if your estate is larger than that, they're going to tell you have too much money. And they have an income kind of requirement that tells you if your income is not being used to pay for care, we won't pay you because you have too much income. So a misconception I get a lot of times on the VA is somebody comes to me, they have no savings, but they have, $3,000 a month of income, and they're wondering why they're being denied for benefits. The problem is, in order to get this benefit, you have to be paying for care. So it's almost backwards of what you would think. I need the benefit so I can afford to pay for care, and the VA approach is you need to go pay for care, and then the VA benefit will reimburse you. Again, there's a lot more I can talk about on any of those topics individually, and I want to leave plenty of time for questions and answers. But if I was to summarize my job and what I've been doing in a quick sentence, it is to take action now and get the tools put in your tool bag so when the need arises, all you got to do is reach in the bag and start using the tools that are there. That works with the medical directives. That works with your trust. That works with the financial power of attorney. I mean, we can talk hours about avoiding probate and how to set up your estate properly, but I think the more focus I wanted to share today with you all is that when it comes to long-term care planning, the thing that you can do to better your own position is what you're doing right now, and that's being educated with it. So if you've never heard of these benefits or anything about them, I'm glad this is the time you're hearing. Again, it's a conversation. You may know a veteran or a spouse of a veteran that's struggling right now and doesn't realize that there's money on the table for them to help pay for their care. And you may have a family member in a nursing home going through a spend down, and they might not realize that there's a way to shelter what money is there to help protect the spouse or help protect a disabled child. There's a number of reasons families do this care planning, long-term care planning, but at the end of the day, if your ducks aren't in a row, you're going to end up in a crisis. And when you're in a crisis, it's like asking me to do this work with one hand tied behind my back. I'm a lot limited in what can be done, and if nothing had been done yet, now I've got to turn to the probate court, and we have to ask their permission for every single thing we do, which can become very costly as well as timesome. So I'm going to stop there because I think I've hit probably 10 subjects that could be expounded upon a lot more, and I'm open to any questions anybody has.
Just raise your hand, and I'll bring the mic around. So, anyone have any questions? All right, we've got some. Definitely got some questions here. So, how do you see when families deal well with the end of life? Like, obviously, we have the, you want to create a living will, like you want to make your needs known, basically. But what's the common thread that you see of families that deal well with the end of life, legally speaking?
Well, when you say they deal well with it, you mean the ones that are prepared for it?
Yeah, so ones that, because when it's like Dostoevsky, or I think it's Tolstoy, all happy families are alike. All unhappy families they're unhappy in their own way. So, like, how is it that, what's the common threads that you see with those particular families?
Well, the first thing I can comment on is the difference between families that are in denial. You know, if you're like any one of us, I help in myself on this. We deny the severity of the situation. We have a loved one starts losing their memory, and we just say, oh, they're older, they're forgetful, and we don't take the right steps to follow through. So the families that actually break through that, you know, and try to take action before it's too late are often well better equipped to handle it. Reduces the stress level of handling it as well. So hopefully that's a good example or answer for your question.
All right, I'll keep going. All right. When, you know, we're talking about a lot of the big expenses like care and things like that, like at-home care, hospice care, not hospice care, but nursing home care, things like that. What are some of the little unexpected expenses that kind of trip people up that you see?
Well, I mean, prescription costs, co-pays. You know, you don't realize that ambulance trip is on you $800. You have multiple ambulance trips in a month, you're going to rack up a bill just to pay for the transportation to the hospital. So those are the little things that start tripping people up. It's really another thing that trips people up is when a family member does not share their ills and forgets to pay for things, and debts and bills get behind. I helped a family one time that didn't realize property taxes were 3 years delinquent, you know, their house, because they thought mom was okay in paying her bills. Little did they know she didn't have any clue about what was going on. Insurance lapsed on the homes. So those types of things lead to bigger financial problems down the road. So again, the planning aspect, if you have somebody, I always ask clients, who's your go-to person? If you weren't able to pay your bills, who would you turn to? And maybe have a conversation with the person while you're healthy and able to, so they can be aware of what's going on. Sometimes the secrecy and privacy of a person it needs to be respected. But if you open yourself up to anything, you're pretty much opening yourself up for a lot of expenses down the road because you haven't opened the door for anybody to let them in and help you.
So, what would you say in terms of, because I'm thinking of like families and relationships and things of that nature, what would you say is the most contentious issue that you see in terms of family at the end of life?
The unfortunate truth as a lawyer, I get to see the bad side of a lot of situations. So this one's the most is kind of grabbing it to a bad, say, which example do I want to share? I can tell you that I have experienced more contention and issues with second marriages and there's children from previous marriages because there is the struggle between the second spouse and the children from the prior marriage. And I've seen this struggle happen enough times, even when the second marriage had been in place for 30 years. By all means, this was stepmom or stepdad. But when the loved one starts to get sick, signs of ailing, there becomes a lot of contention between what the kids think should happen to their parent and what the spouse wants to think should happen. Again, if you have a plan in place, there's no question about it. With no plan in place, we end up court arguing over who's going to be the right person for the job. And the law says, well, the spouse, the children. But before the spouse and children even get a say, it's who you authorize in your advance directive to be this person in control. So, I mean, you have the choice to shortcut that process. Anytime I'm doing planning in this type of family dynamic, too, I always draw out and make sure that the family is aware of the planning that's being done so one person doesn't step on the toes of another. So there's a lot of contention there. Really comes into play, too. I've experienced spouses that were so worried about financial duress that they concealed the illness, tried to keep the person home too long, which led to worse health problems. You know, and again, grab into the bag and share all kinds of examples with you. And I've had families contact me and say, you know, oh my gosh, APS is looking into me. What did I do wrong? And I try to explain to them, if APS is being called, it's because there's a concern that needs to be addressed. And if they look and the concern is not as bad as maybe it was presented to them, that's a good thing. These things are there to protect you and to protect your loved ones. Too often we look at the AP worker, we look at the probate court, we look at the state worker and the benefit program, and we see them as the bad guy, the person who's the gatekeeper keeping us from a lot, when they're just humans like us, trying to help. You know, so you got to change the way you look at the individuals that are there helping and realize that we're all looking out for one thing, and that's your best interest.
So in the answer to that last question, you mentioned APS.
Yeah.
Could you explain a little bit what APS is, kind of and how they protect people from exploitation and that kind of stuff?
Yeah. So APS, the acronym, Adult Protective Services. They are a state-funded, county-funded program. They are individuals who will research if you are concerned about somebody being exploited financially, being taken advantage of, maybe not getting the medical care they need. You will help in what you can do about it, right? You look over, you see the bad stuff, you go, who am I? Well, you are a citizen who is looking out for other citizens, and you can always make a call to the Adult Protective Services and report a concern. When you report a concern, it doesn't mean that is the end of the case. That just means you're asking for somebody to come look into it. I have had cases where that was well justified, and the person needed to look into it, and by the time they got to me, we were already in the probate court with a guardianship issue. Because what happens is when they do their investigation, if they find no foul play or nothing wrong, then they close the investigation. They say there's nothing wrong here. On the other hand, if there's something wrong, then they report it to the authorities, usually followed up with a guardianship petition to get the courts involved so the judge can actually step in and protect the individual who may be being taken advantage of. So hope I can keep going. I think that really summarizes what we do. I don't look at it as bad guys, and that's something I always try to clarify with my clients. They are there for your protection. And how did I say it to a client the other day? I said, you know, for hundreds of people out there that are doing it right, there's one person out there that did it wrong. And we cannot assume that because a majority of people are doing things right, that one wrong person, shouldn't be exposed. So sometimes a good person doing everything right might get reported to Adult Protective Services. That's okay. If you're doing everything right, don't lose any sleep over it. Be honest with them, tell them what's going on, and they're going to close the investigation. But, you know, you got to go through all those ones to get to the bad ones, and you can just give thanks that there's a program. There's people there that will protect them and get the law involved when nobody else may be able to. Oh, yes.
Sorry if I missed this in the first part, if it was covered, but based on your experience, what advice do you have on how to select people for the various roles that you need? And, you know, what advice do you have for people who don't have children, for example? And I listened to something several years ago where the person with experience actually advised against a family member because they were too close to the situation, which for me has kind of gotten in the way of putting this all in place because it's hard to figure out who to ask. It's a big responsibility.
Yeah, no, that's a great question. I would, when I'm interviewing a client for doing planning for them, I always start the question by asking who their go-to person is. It's a very informal way of just saying who you turn to when you need help. You know, if it's a married couple, a lot of times it's a spouse. I follow up with a question, well, what when your spouse are in an accident? Who's your next go-to person? I like to get through a few people. Now, not everybody has a spouse, not everybody has a child or a parent or a family member, a close family member. So then we start looking and saying, well, it goes back to the question, who's your go-to person? Because unless you're a complete loner and have nobody in your life, there's usually a group that you may be a part of, whether that's a religious organization, a charitable organization, a group of friends that you go out to breakfast with. I mean, there are a number of circles of your own life, and I start by saying, look at those circles. There might be a pastor or somebody in your church that you turn to and trust emphatically with making these decisions for you. I do often counsel on making sure that they've got a strong spine. You know, you don't want to appoint somebody in one of these roles that's going to push over. You want to somebody that's going to stand up to you and know that they do what you need to do or have done. So at the end of the line, there are professional organizations out there that you can turn to when it comes to medical decision-making, professional guardian programs and things like that, where they will actually take on the role as your patient advocate. A lot of those types of agencies have fees involved for the work they do, and that's fine. It is a job. It's an underglorified position. I tell people all the time, don't battle for it. If there's two people that are well qualified, hey, let the other person do it. Sorry, I try to stay very relaxed in the tone and the way that I talk about stuff because it's a very heavy conversation. And if you have nobody to turn to, at the end of the road, the state or the probate court will have somebody for you. But it's always a matter of go through your own first. Who do you want? And check that person. You always got to follow up and make sure that person would be willing to do it for you. If they do, then great. I recommend at least one step, maybe two. You always got to think in contingencies. What if person A can't do it? Well, I have the next person in line that could step in. If both of those people are gone, I have a third person in line. I think I've had a plan one time, 5 different backup agents, and that was great. Compare that to the plan that I had that was a son and a mother, and there was nobody else. Son was there for mother, mother was for son, and it was like, well, who are named as a backup? And there was nobody. And it made it a lot harder. We had to turn those professional services and basically say, if you don't want to go talk to them now, somebody's going to have to petition the court to go talk to them later. Yeah, hope that helps.
Thank you. So, what should, if someone is looking for a lawyer or an advocate, what questions should they be asked before they enter into that relationship? And what are some red flags, or like only red flag things to look for?
Yeah, no, I'm glad that you asked that question. The first thing you want to be looking for is somebody that obviously has been doing this, has experience in the field. I find it ironic that now that I have over a decade of experience, I talk like that. The first I said, well, how am I supposed to get experience unless somebody gives it to me, right? So experience is not only the deciding factor, but it is definitely a great place to start. Have you done this before? Understand the difference between your estate planning attorneys and your elder law attorneys as well. A number of referrals in my office come from other estate planning attorneys who do not practice or specialize in long-term care. So you want to make sure when you're talking with an advocate or an attorney about this, make sure that they have filed a Medicaid application before. If you're a veteran or spouse of a veteran, make sure they're accredited with the Department of Veterans Affairs that can help you with that. Almost every elder law attorney I personally know offers free consultations. So I put that out there in my office as well. I can't tell you what I can do to help you, and I don't feel right charging you until I know what's there and what's needed to be done. So you really shouldn't have to be paying for an initial consult. If you are, there are attorneys out there that will charge an initial $200 or something to meet with them, but there are plenty of other ones who won't. I always tell my clients, anyone that tells you not to get a second opinion, be wary of. I have no problem with a client talking to me saying they're going to another attorney. I think it's great, and I recommend it to anybody here. If you talk to somebody, it doesn't hurt to get a second opinion in what they're proposing for you. Some red flags to point out to individuals is somebody who tries to sell you. This is not a market that we need to be trying to hard sale to clients. Present what we can do to help, quote a fee, and that fee should be reasonable, and then choice is yours. So if somebody's trying to push this, saying you have to do this now, if you don't do it now, and they're pressuring you, that's a red flag to me. I've never cared for sales. It kind of hit me at first when I tried to sell myself as an attorney, but I've just learned if you do a job for people, that sells your services well enough. Last thing I'd focus on is make sure you ask what their fee structure is. Understand how you're going to be charged. My firm, I've always worked on a flat fee basis when it comes to this type of work. So look, I see what needs to be done, and I get a fee. And we every time I do this, I always say, you know, for Medicaid planning, it could be anywhere from, you know, $1,000 up to $10,000. I've never charged more than $10,000 for a case. That being said, I have seen attorneys charge upwards of $30,000, $40,000 for something that I would have done for $5,000. So that's going back to the second opinion matter. If somebody gives you a quote that doesn't pass the smell test, maybe you should go find out if there's another attorney there to get an opinion in a different quote. And if the fee is reasonable, just can't afford it too. There are other pro bono services or attorneys like myself that will actually greatly reduce our fees for individuals who can't afford to pay for the service. So, you know, these are the things I tell every client. When I do workshops, I have no quarrels about the way I charge, the way I work with clients. And I present it, you know, $2,500 to $10,000 on a Medicaid case. Could be less, there's a lot of money there. Never been more. Inflation going on right now, but my rates have been the same since I started doing this in 2009. So.
All right. Well, was there any more questions from the floor? All right. Well, thank you very much. All right. Well, thank you all. Thank you all for coming. Like I said, I've been Steve, and we've got some surveys to fill out at your chairs. If you are watching us online, hello. We have a short survey as well in the notes, the video notes, right below this video. So, and we'll ensure that Mr. Hodge and Dr. Bella's been here. Did I get it? Whatever. Sorry. But I'm sure they'll be able to stick around if you have more questions. We will be having our exercise class at 12:30, so there for that, and we'll be discussing the book. We'll be discussing the Gawande book about end-of-life care at 2 o'clock. I'm really excited to talk about that with y'all. So thanks very much, and have a great rest of your day. And we have parking tickets to let you out of the lot if you did park in the lot.